I've got 8:30, Liz. I don't know.
Yeah, go ahead. Okay, I think we can start. And we've got 29 people. So for this committee, we really just do a majority of those present. There's not like an official quorum of folks. So I think you're good, Kel.
Okay, so we'll get started. For those of you who don't know me, I'm Kelly Vaughn. And I've helped Dr. Register and even Dr. Patterson with this meeting since its inception, I think. Dr. Register was going to lead the meeting this morning, but she has been called away to a case. And so it's going to be on me. So welcome. Make sure that you have either scanned the QR code or clicked on the link to capture your attendance. I know Gabby also sent out the minutes earlier this week. Do I have anyone that has reviewed those minutes, can give approval of the minutes?
We could just take a motion in a second, and then if we want to just vote by any objections, that way, no, people don't have to unmute.
Right.
I'll move to approve. Emmanuel, I'll make a motion.
Thank you.
I'll second it. This is Damien from Emmanuel.
Thank you.
Thank you. Can y'all hear the lawn people are literally right outside my, so
No,
I
we can't.
I
apologize.
cannot hear it. We cannot hear it. So you're
Good, because it's loud.
Well, at least you know the Emmanuel folks are awake.
All right, we're gonna move on. Liz, you go ahead with your updates.
Yeah, I have just a couple updates that are really germane to the level 4s. But first of all, we're dived right into the legislative session. So ramping up for that. Nothing big on the commission front this year. We do plan to do our 2 updates to the Senate Health and Human Services and House Public Health Committees. And we'll do our appropriations for FY26. We don't do amended anymore. So I'll keep you all posted as we get down to the end of session when all the budgets get approved. But things are pretty predictable for us now with the trust fund, with the way the super speeder funds and the fireworks are handled. So no surprises anticipated there. Now for the level 4s, just a quick update on 2 things. One is the IRR program. And thank you so much for everybody who got, I know it's hard to get contracts through legal. I really think you guys are going to love this program because I know many of you, your trauma person in your building is only one person. So they can't do data validation on each other. So this is going to be a great program. We've got a couple contracts between the centers and Qcentric still pending, and those are making progress though. So that's good news. So those are almost finished. And then GTC, because we're paying the implementation fees, we have a contract with Qcentric as well. We just had to fine tune the scope of work and the deliverables, and we have, because it exceeds threshold, it's got to pass approval for sole source. So we had to do all that. So all that's pending, but moving through at the appropriate pace. So we wanted to get a January start. Obviously, that's not going to happen, and these things are often delayed because of contracts. So no, that's anticipated. Now, there were 2 amendments that went out, and I think there was a little confusion. So I want to make sure that you guys have time to ask me questions just in case the confusion still exists. One thing is that one of our astute colleagues at one of level 4s noticed that the contracts were for a period of 3 years, and we're only funded. I think we'll probably continue it for some time till whenever you guys find it's helpful, or whatever we want to do in the future. But standing it up was the funding was for 1 year, so we didn't want anybody to feel like they were obligated to it or feel uncomfortable around obligations. So we had Qcentric issue an amendment to say that it was a 1-year term. Now they did leave an auto renewal, because what we don't want to do is, if you continue it, we don't want them to disconnect the connection to like your EMR and the registry to be able to go in. We don't want them to stand down. So we just need to be mindful of that. And I think what we're going to do is I'm going to get a copy of all your executed contracts, and we want to just make sure we know when the dates are, when the stop and start. the bottom line is if you don't if you don't use the services, like if they're not IRRing cases for you, you can't get charged anyway. So they would auto disconnect you after a certain period of time if you weren't using weren't using the services. And then the second amendment that went out was actually from GTC, just to add the money to your contract so everybody felt comfortable from a financial perspective that you were going to get your reimbursement. So we added up what the monthly fee was for that app that they have, the clinical data validation, where all the information about the IRR goes into, as well as the services for the actual re-abstraction of the chart. So figuring out what the average was for that, we added that to your purchase order and added that to your contract. And I want it to be easy, like, this is to help you. This isn't to make it be sort of, financially hard for you. So if there's any questions, please, whoever does your billing, we just added it to the same invoice. So it's all on one thing. So it should be pretty straightforward. But if there's any consternation or concern or anybody's confused, and the IRR piece doesn't start until everybody's executed and we're executed from the implementation perspective. So that's the IRR. And again, happy to answer any questions or have one-on-one calls with you. That's probably easier if we need that. And then the second thing is, I forgot to mention this at our November meeting, but 3 years ago, about 5 of the level 4s had consultative visits with Pennsylvania Trauma System Foundation. And now we're 2 years out from that. I had a conversation with them about, could you come back in the fall if centers were interested? I'm sure the commission would support doing another visit just to, for a check, see how are things going? What other help do you need with performance improvement? They said they would be happy to do that. We could talk about that. Then they came back, though, after our November meeting and said, they're having a new implementation of a software for their entire state. Their registry is migrating. So they said, we can't come back in the fall because that's the flip switch for us. So what we could do is do something in June, and it wouldn't be like it was before where you filled out a PRQ, almost like a site visit. It would be just more of like a performance improvement consultation. So basically, whatever some of the weaknesses were found on your original report and things that you were working on correcting, kind of getting input and feedback on what does this look like now? Are we on the right track? Did anything else pop up that is an issue? So they're willing to come back and do that. And on Monday, the commission voted and they approved a placeholder in that. So if you're interested in that, I do need to know what centers would like to participate in that. It would be a half a day somewhere in the June timeframe. And once we know how many centers are interested in having them come do their little one-on-one consultation, they would be happy to get those scheduled, but we'll just need to know how many so they can plan accordingly for coming to Georgia. So I will to the centers that are eligible that participated in it back in 22. I will send you guys an email after this call, and you simply just respond to the email and tell me that you're interested, and we can get that going. And I think that's it, Kelly, unless folks have questions now that you want to ask about either one of those, the IRR or the PTSF PI consult visits.
Hey, Liz, this is Rachel. I do have a question. It's something that I was going to bring up in my report out for the Trauma Connection group, but there was a little bit of confusion in regards to what the actual role is of Q-Centrics. Now, my understanding personally was that it was just for the IRR and that they were going to be re-abstracting and performing that data validation for about 10 to 15% of our charts, I think, was kind of what was worked into it. But there was a question posed to the group in regards to, are they expected to complete any type of initial data entries on behalf of the facilities into the registry, like into V5, or are they expected to be pulling out any data and completing submissions for like the quarterly data reports or anything like that? Can you
Yeah,
just speak to that?
Yeah, thanks for, this is solely an inter-rater reliability program. So they are just, for lack of having someone in your building to go behind you and re-abstract the chart and do the matches where you agree or disagree or agree to disagree, that kind of thing, and then talk through where some of the opportunities are. That is it. They're not doing any re-abstraction on your behalf. That's a whole other different price point and a different program for them. But thank you for asking that, because that's a good point of clarifications.
I have
Sure,
a
thank you.
question too about something that you said. So, for those of us that have signed the contract, did you say that we're not going to start the process until everyone has had their contract signed? Like we're all going to start together? Is that
Yes, you have to start together because you can't get your implementation done until we execute the implementation portion of it. So it just takes a little time, and they're trying to work up their, workforce, because they have to plan for, this is pretty low on the workforce because all of you are fairly low volume. Nobody's, really bananas volume. And then again, it's only a portion of your charts. It's not one-to-one inter-rater. So it's fairly low volume. So yeah. Great question too, though.
Hey, Liz, I'm going to ask a question just because I'm the registry chair for the state. So does Q-Centrix then provide you feedback with most common issues that we can then share from a registry committee perspective? Or should I reach out to the centers and find out what their feedback is, like what they're finding are most common? Like, how does that part work?
Yeah, that's a great question. So the strength of this proprietary thing that Q-Centrix has, and I can send the group back out the materials for when we had the call, is they have the clinical data validation module, which is essentially where they enter all of the information in so they can do the match mismatch. And they'll give accuracy for each area. And so, for example, they would help you figure out, is it a problem with if there's a inconsistency or a mismatch on, timeliness, like arrival times, activation times, vital sign times, whatever, those kinds of things, or GCS calculation. Is it an error in abstraction, or is it we're not pulling it from the right place? So they'll look at those kinds of things. And then there's also injury coding, right? Did we code according to what was on the diagnostics or what was in the notes or whatever? So, and then if there's a procedure, then procedural coding. So I think this will really be helpful because you can probably bucket where the opportunities are, and then that will help you guys figure out how you want to target education. And then maybe for the other centers who are bigger and have more registry manpower, somehow if they can report out in their IRR process in their own facility what their opportunities are, maybe then we can really aggregate it and really do targeted education. I think that would really help. Now for the centers, it's up to you guys what you're willing to share. And Rachel, you may want to take this back to your group, that the nice thing about the CDV is that you can export your IRR accuracy rating in Excel. So, there's no patient data. It's basically just, I haven't seen it myself yet, but I would think it would just say kind of what your rating was. It might have where the mismatches were, again, whether it's an abstraction error or what do you call that, Kelly? The hierarchical, like where you pull the information from,
right,
or again, diagnosis coding, procedure coding, that sort of thing. So there might be a way to export the Excel in a way that would show that. We'll just have to kind of take a look. And again, if it's in Excel, you guys can manipulate it any way you want before you share it. And then you can aggregate it. And that would be really powerful to say where we need to do education, especially because Gina is working hard to get, since ACS doesn't really offer anything for level 4s in terms of, I don't even know that ACS releases their general NTDB report like they used to, which at least that was something for you to get back and you could look at and see, hey, where do I compare with this, But Qcentric's Arbormetrics, Gina's program with GQuip, all of the level 4 data is going into that. So we're really hoping we can build out something for you. But the first thing is to make sure that the data is really good, because if the data is not good, it's going to be really hard for you guys to draw comparisons. And we don't have a sight line into what that looks like. We have a pretty good sight line on the level 1s, 2s, and 3s because you guys do TQuip, and TQuip will pretty, they're pretty harsh. They'll kick you out if your data doesn't meet certain standards. You're excluded from benchmarking, and you get this really, ugly note that says, you're out basically. But, we don't have anything like that for level 4. So it's going to be really groundbreaking for you guys.
Yeah, and I think doing it aggregate wise, and like you said, I can reach out to the 1s, 2s, and 3s to kind of see what their issues are in their IRR. And then we report it out through registry at a meeting and talk through opportunities for education and best ways to address those issues. I think that's a really cool idea.
Yeah, and even if you just said everybody, each center could report out like what percentage of your IRR opportunities fell into this bucket, like of everything that anybody had a mismatch with. Was it abstraction? Was it hierarchical? Was it injury coding? Was it procedural coding? Or there might be things I'm missing, but if people could just report out where their highest percentage was, that would probably be really powerful to you.
Mm-hmm. All right, does anyone have any other questions about the possible PTSF visits or the Qcentrics? I don't see anything in the chat. All right,
trying
thanks,
to monitor
Liz.
the chat. Yeah, no, thank you. And thank you guys too. I like, it's just amazing, we like Rampa, we, get these ideas for programs, and I know like it feels like, oh, like let's just get started already, but we're really ramping it up pretty quickly. So it's really exciting. And thank you guys so much for your interest and your willingness to jump in and, make things better. And I think that overall this is really going to help us and really going to raise it to the next level. So thanks, Kelly. I'll monitor the chat while you're doing the rest of the.
All right. Courtney, I saw you're on. Do you have a March pause update?
Not a real vital update. We are, I met with Damien this week. We're trying to get back in touch with the vendor. I did ask at the last meeting for people to let me know what equipment they wanted. There was some question about some of the equipment we got. They thought was too bulky, too difficult to handle. So we're trying to figure that out. And I have got the vendor that I'm interested in using that would like not only to do the videos, but help develop a platform for future videos that we could put on for EMS and for the hospitals. And my key still remains to bring the 3 players into the room together, the EMS, the physicians, and the ER and trauma staff. So that's the only update I've got, Kelly.
Okay. All right. All right. Liz, what do you have for this action planning I think you've already talked through that part, right?
Yeah, I think, I just didn't, we covered all that.
The ACS system consult rural focused review.
Yeah, basically all the things we're doing now really are in support of that. The IRR program, having the PTSF come back and, and
Okay.
talking about education. We don't have, I know we had Dr. Register and I talked about that, talked about the rural and non-trauma center resource. We don't have any updates on the, she had some things she wanted to talk about with the group, but we can certainly wait until next time or when we're all together at Callaway next month.
And we are not meeting as a level 3-4 group in Callaway. This meeting is taking the place of that as an official group meeting in February, correct?
Yeah, you don't have, your in-person was November since we were in Cordeal, so we don't have an in-person. Not to say that you guys can't, I know like that schedule feels like it's like a freight train and we're running from
does.
room to room, and we try to make it so that you guys have some time to we only meet in person twice a year as a bigger group, but and unfortunately we have to reserve rooms so well in advance when we do the contracts for these things. So there might be some time and space for informal meetings and such. So we can take a look at that if folks feel the need to connect on, or feel it would be beneficial to connect on something.
All right, Rachel, do you want to do your Trauma Connections group update?
Yes, ma'am. Excuse me. We welcome, like we've met over the past couple of months. We continue to keep our monthly cadence. So we do meet on the third Wednesday of every month, from like 11 to 11:30. And so if anyone does not have that invite, please let me know, or Christy Mathis, and one of us can get you added to it. We were able to welcome a new TPM over at Piedmont Cartersville, Karen Barrett. So she joined us for the first time recently. So it was good to have her presence there and her input. We had, prior to the completion of it, we had sent out like a reminder for the Survey Monkey for the GTC funding that you were requesting regarding trauma registrar education opportunities and needs. We did a lot of discussions regarding trauma flow sheets. So we just discussed and did, round robin type thing about who was utilizing trauma flow sheets, how they were utilizing. We shared a few of those across the way from different centers. So thank you to those who shared those flow sheets. And I am suddenly having a light bulb go off that I have not sent those out to the group yet. Sorry about that. I will get those sent out. So they will be shared in a little bit. We did talk a lot about validation reports, and this is kind of going back to what we've been talking about data validation in the registry and how we can do that. So a lot of the centers have met with Gina and Marie, and they've gone over the data validation report that exists now in ImageTrend and the benefits that that can bring. And then a couple of our centers also shared the validation reports that they have manually built. And so they are willing to share to whoever needs one or whoever is interested in manually building their own within Report Writer. So that was an opportunity that came out of the group. One of the things that we had talked about was documentation in the registry regarding the ER providers, because the level 4s don't have the trauma surgeon responding. And so we have found that within the DPH quarterly report that pulls the trauma surgeon response time, it's pulling from a field that we're not filling because we don't have trauma surgeons or some facilities. And so we talked about how to troubleshoot that. We talked about one potential opportunity was to either duplicate your documentation in the registry and put in your ER doctor in both the ER and the trauma surgeon with just have it duplicated in both spots so it'll pull on the report accurately. Another fix would be to have the facility reach out to ESO support and get them to remap the trauma surgeon response report in Report Writer in order to pull from the emergency provider field. I hope that makes sense. That's the fix that I had to do. If anyone has questions, feel free to speak up or ask. Just giving you all a few seconds for that one. We discussed the Q-centrics, which we've already talked about. I've already posed my question that the group had to Liz. So again, thank you, Liz, for answering that one and providing that clarification for us. And then the other big issue that we were talking about most recently was our TQIP data submissions. So this brought up a couple of questions, and Kelly, this is potentially something that you could take back to the registry subcommittee. We just found across the board that some people are, the registry has its minimum requirements of cases that have to go in, which are the ones that meet the trauma inclusion criteria. Some centers have opted to input all of their trauma activations into the registry as well to pull more aggregate data on their reports. But they have found that in doing that, it looks like, now this is all correlation, I don't have proof, we would have to speak to them specifically, but some of the centers have found that when they were in practice of putting in all of their trauma activated patients into the registry, in addition to the inclusion criteria met patients, their submissions to TQIP, their reports and their results were all skewed. But then when they stopped adding in all of the activations that didn't meet inclusion criteria, they found that their TQIP reports corrected. And so they did some internal validation in the sense of they were making sure that the correct boxes were checked, that they were supposed to be reported or that they were not supposed to be reported. They also validated that their exclude or include for TQIP boxes were checked as well. And they said that all of that stuff looked to be correct. So again, I don't know if it's a mapping issue within the registry to how these data submissions are sent out to these other entities like TQIP, or if it's something else. But that's something to that may be discussed more, I guess, further along the line or in different groups to kind of get an idea of, one, if anyone else is having the same issues, and two, if they know how to fix it. So those were the big things that came out of the connections group.
Yeah, we can definitely, our meeting is this week, so I've just made a note, so I'll bring that up. And because that'll pull in the 1s and 2s and all the centers, so we can kind of round robin about that.
Excellent. I should be there, so I can, I'll be there for some more context if they need it.
Okay.
Thank you.
No problem. Anybody, I'm gonna do, Cheryl, I see your chat. I'm gonna go ahead and go into this performance-based pay, and then I'll let Cheryl talk about Trauma Awareness Day. So Gabby or Liz?
Yeah, Gabby will share her screen and I'll turn it over to her, Kelly. She has done a huge amount of work. We're trying to do a big revision on the Trauma Center PBP this year, and most notably, it's trying to create tiers for the PBP around meeting attendance, so it's not a one and done, right? So, and we actually, we love to steal great ideas that other people are doing, and in the spirit of everything that we've done with the help, Gina has gotten great guidance from our friends in Michigan at MTQIP, and they do sort of a tiered thing, and I think that will serve us much better. And so Gabby has a PBP work group that she put together, and Kelly, you sit on that. Are you on that one, or are you on just the readiness discussion? You're on that.
She's
okay,
on
Kelly, you're in everything. Yes, she is. Thank you, Kelly. But we wanted to just kind of bring it here to this group and Gabby give you kind of a first look at it. We've extended the timeline a little bit. We're going to do what we did with the last big revision, which is do an open comment period so that, sometimes people don't feel comfortable speaking up in a meeting or whatever. So what Gabby wanted to do was bring the, preliminary kind of high level overview of what the work group has done through to all the committees that this would touch, this committee, the TMG committee, GCTE, the trauma administrators, and then open it up for that open comment and see how people are feeling about it. And then we can make some final revisions to it. And then hopefully before the end of the fiscal year, get this passed, get it to the full commission, and then get it passed. So Gabby, I'll turn it over to you.
Thank you. And as Liz mentioned, we have a PVP work group of about 8 stakeholders. Kelly and Rachel are part of that group. So thank you so much for your feedback. We just want to make sure these edits are reasonable and not cause much heartache for you all. So the first page, I did send this out with the agenda for review. The first sheet is a change log, so you'll see a comprehensive review of any additions, criteria edits, percentage changes, reformats, and anything we removed from the PBP. I did want to highlight that for FY 2026, there were 2 outcome measures added. This will be something that we're looking to transition for future PBP to mirror MT-QIP. I'm going to blow this up a little bit because it's probably hard to see. So we have here the timely VTE prophylaxis and timely surgical repair for geriatric patients with isolated hip fractures. And this will be added to level 3s. Level 4s will not have this. Gina, did you want to provide a little bit of background regarding those 2 outcome measures?
Yeah, sure. Be happy to. As Liz mentioned, we really mirrored what MT-QIP has done because they started this many years ago, and those were the first 2 measures that they started with. So and have had success with. So it seemed very reasonable to start there ourselves. The hip fracture repair is already built in Arbormetrics. And we are working on the VTE prophylaxis process measure. So it should be in there probably in the next 3 or 4 months. So that way everybody will be able to see those metrics in Arbormetrics, see where they're at every quarter. And that's where we'll be able to pull it from as well. So that's, that's really why we started there with those 2 measures. And they are in the TQIP report as well. So those are things that hopefully centers are kind of used to having in their on their radar. We've also got a VT work group that's working now. And Luke Galloway, our GQIP scholar, is doing some deep data analysis on raw registry data that we have to see where we are at there. And the group's also working on a statewide VT prophylaxis guideline that we can share for centers that may be struggling a little bit. So that'll give some time since it'll be a zero risk to start out with for centers to kind of, see where they're at, get to working if they've got some challenges.
And Gina, overall, I think we do much better than this. Like before, we actually did a paper on this back in 16, 17 on VTE, and it was abysmal. But this is one of the things I think we've improved on. And just to, Dr. Dunn, when Gabby did the same high level overview to the finance committee, just to kind of update them on where the PVP work group was. And there was some consternation about, well, neurosurgeons don't like to, they don't want to do VTE prophylaxis in a patient with a head bleed. That's why there's a threshold here, because a certain amount of patients are going to fall out, right? So, and there will be exclusions, right? And so the patients who meet exclusion criteria would not, be included in this. But this is to make sure that really the patients who should be getting it are getting it and setting that at some threshold.
Correct. So that's why the threshold is, as low as it is, because, that was one thing when we first started talking about it, everybody was like, well, it should be higher than that, but you've got to allow for those populations that, would not get it within 48 hours. And we also limited it to the trauma admits, because that gives us a little bit more control, right? Those patients that are admitted outside the trauma service, it's a little bit harder to control or try to move the needle about what's done. So again, mirroring what Michigan has done. So and I know at the GQIP meeting, Luke's going to present an even deeper dive of his analysis. So we'll really be able to see where people are at getting started. And his initial analysis, we're pretty close. Most centers are pretty close to, where we've set the threshold. So we don't really see, hopefully there'll be, too many outliers. It'll need a lot of work to get here.
And for these two outcome measures, they're going to be 0% risk. So really FY 2026, kind of that pilot to see where we are. And so you won't get any PVP deductions for FY 2026. And then something else we added for level 4s is trauma registry professional demonstrate evidence of one of the following courses, which is AIS 2015, trauma registry course, or ICD-10 course. Or if you completed all of those, demonstrate 8 hours of continuing education. And those are really much the big changes for level 3s, level 4s. And then proposed PBP, the second sheet, you'll see this is what you're used to looking at, where you have the criteria for all levels. And then you go to your 3 or 4 to see level 3 or 4 specific PBP criteria. And anything in red is where we tweaked or added clarification, as well if it's a new criteria. And
Hey,
then when we go,
Gabby,
oh, go ahead.
I just had a thought on that continuing education is, it's fiscal year 2026, which is July 1, 2025 to June 30, 2026. But the scorecard typically is due in April. So will it be looking at the 2025 calendar year for submission? For the 8 hours?
That's a great question. That is something we have to bring up to the PBP work group regarding the transition from calendar year to fiscal year and that PBP scorecard. What we're looking at is possibly deferring the PBP scorecard to August. And there's a whole bunch of change also that we'll just need to review with that. So
Okay.
that's a great question, but to be determined.
Okay.
Yeah, thanks for asking it, Kelly, because we want the PBP there, like we want to try to avoid these like rushes at the end of the fiscal year to get stuff in and measure it, right? It shouldn't be like that. In fact, we thought it'd be great if we could mirror how uncompensated care is done, right? It's retrospective, but then we don't want to have this big like 3-year delay in when we implement new criteria, because then some of that gets outdated after a little while, and it's hard to keep the meetings all squared away and whatever. So yeah, to be determined, and it's going to come back to your committee to really look at kind of how do we do this, and not changing the base of because you're involved in the readiness group, right? So we got the readiness survey coming up. So we want to have the PBP be this just base set of things. And then the other stuff is just, you have to complete it in order to be compliant with your contract, right? Like if you're going to get readiness funding, you got to complete a readiness cost survey because we have to keep up with that,
Right.
So, yeah, so that this doesn't change that often, it's predictable, it's reliable, and it has enough time that it's kind of like CMS. And for the administrators that are on the call, you guys are going to know this phrase well, where they say your past performance predicts your future financial viability, right? So have enough time where we're not rushing to make calculations, have enough time for you guys to be aware of the criteria, make sure you've got a plan to get into compliance with your designees for the meetings and things. And then know predictably when the measure is going to occur, and then know what contract readiness portion that affects.
Okay.
So that's your group's charge, Kelly. No pressure.
Right, no pressure. Sorry, Gabby, go ahead.
No, you're good. I'm going to go to the specific level 3, level 4 sheets, because this is where it's really different and maybe a shock when you first look at it. So we did change the breakdown to be by role for meeting attendance. So we organized it by appointed senior executive participation. It's the same level of meeting attendance, But now rather than having all or none approach, you have tiered levels of participation. So if a senior executive attends the 3 virtual committee calls and the in-person, you get that 3%. But let's say you miss 1 virtual call, then you get 2%. If you attend all the virtual meetings but no in person, then you get 1%. And then if you didn't attend anything or just 1 meeting, it is 0. But that kind of eliminates where you may have missed 2 meetings and then you get 0. Now you have just a different level of participation. And this is just for eligible criteria where we could tier it out. There's some where it's just going to be yes or no. But you'll see here it's trauma medical directors kind of have that same tiered participation. Trauma program managers, trauma registrar participation. And then after that, it's just the general criteria, like participating in the level 3, level 4 rural committee meeting. At least 1 trauma program staff should be present, and it has some PVP and tiers for participation on that. I did want to run down to those outcome measures because there are tiers for that. Again, it's 0%, but this is for the future. So you kind of see where we're going with the tiers. Any questions on that? And then level
How does
4
that-
is the same deal.
So how does that work as far as a level 4 that does not have a registrar? Like the TPM is the registrar. Is it kind of NA, or are you just putting yourself in that spot? Like I noticed it said full or part-time registrar.
Or level 3s?
No, for level 4s. Aren't you on
Level
level
4s
4?
don't have that.
This is,
I'm
Okay,
this
I'm
is
I
sorry.
was
the
on
I thought you
level
were on the
3.
level 4
Yeah,
one.
this is the level 3 sheet, Christy. I was afraid people might get a little bit nervous about that. Yeah, Gabby can show you the level 4s, but again, it goes back. The percent at risk is not changing, so you're still just, I think it's 19% at risk. And you have much less criteria because you have much less funding. So, again, it's the same. We're creating more opportunities. So I hope the comments from the group are that you like the tiers because it's much less jeopardy for you for that. So yeah, Christy, you don't have the registrar requirement because
Yes, I thought that was great. I'm sorry. I just thought you
yeah.
were on the 4 one, and I was like, I'm confused. Okay.
Yeah, no, 3s and 4s have to have their separate because they're so different.
There is
And
a registry one where it's they added trauma registry professional. So that would possibly be the TPM to demonstrate evidence of the AIS 2015 trauma registry course or ICD-10 course.
And Christy, you meet that now, right? Like you have as outlined, I think that's in the yellow book because or orange book, we're still on the orange book criteria for you. So that was
Yes.
required still, right? Yeah.
Yeah.
Okay. So you'll meet that because you guys have to do that anyway. So
And then some criteria you'll see parentheses and numbers, and that is just referencing the ACS standard to where you could probably go to leadership and say that you are meeting an ACS criteria by meeting this PVP requirement. That is pretty much the gist of it. We still have some final tweaks for level 1s and level 2s. So the PVP work group is going to meet February 5th, I believe. And we'll also be discussing that PVP impact cadence and scorecard fun stuff. But we just want to give you a general overview. We will be sending this out for open comment period once it's a little bit more finalized. And then we're going to put this in front of the committees just to make sure everybody's got eyes on it and knows what's coming up for the upcoming fiscal year. I think that's it, unless there's any questions or comments.
I don't see anything in the chat. or hands raised.
Love it, hate it,
Yeah,
Maybe
live
they're
with
still in
it.
shock.
it does
Still
look real.
digesting.
Now, I've been, like she said, I'm on that committee, and so I've seen that multiple times, but now looking at it from a large group perspective, I'm sure it's a little overwhelming, and it's kind of small on a computer screen. So once it goes out for open comment, people can kind of chew on it for a while.
And I did send it out. I'll send it out again with whenever the meeting minutes go out, just so you can keep looking at it. And if you have any questions, please just let us know.
Or just shoot us comments if, something doesn't look right. Once, I think that sheet that you're all familiar with like the little red will help you kind of wrap your head around like what's different. Where it gets a little bit long is where we put the tiers in. That's actually the thing that lessens your risk of money. Because again, if somebody can't make it or whatever, it's that all or none is gone, and we have, again, our colleagues at MT-Equip to thank for this, because they had that teased out really well, because they do the same thing. They do twice annual in-person meetings. They're not as expansive as we are with administrator involvement. And by the way, the presentation that our G-Equip scholar, Luke Galloway, is going to present to you on the administrators, that he's going to do that during your portion of the meeting. So you'll get to see kind of in aggregate where everybody is. So that'll be helpful. Thanks, Gabby. And great job with the work group and your organization of it, and getting this hard edit done. It's been we've been talking about it forever, and we're finally getting it. So it's exciting.
Yeah, Gabby, thank you for keeping us on task too with all of that. That's a ton of detail, tracking changes and edits and conversations and sidebar comments and base camp comments. And I mean, there's a lot of activity that goes on with all of us, and she manages to corral it all and make it into one big document. So that's pretty impressive.
Thank you, Kelly. Appreciate it.
Cheryl, I know you've got an announcement. Do you want to do your?
Yeah, that's fine. Thank you. Just a quick update. Want to make sure everybody knows what's going on. We had identified January 28th as Trauma Awareness Day. It would be our first time back under the Gold Dome since COVID. Now, some of you on this call have registered, and we look forward to seeing you there, but there's been a slight change. You heard Liz mention earlier that the session has started for the Georgia General Assembly, and that was Monday. Well, a couple of days after the session started, we were advised by the Senate that we should change our Trauma Awareness Day, because on the 28th, there's going to be the State of the Judiciary. So there really wouldn't be as much time as we would like for us to be able to interact with the senators, that we wouldn't have had our resolution read from the floor, and we wouldn't have been able to actually go down on the floor. So as a result, we've been scrambling to get a new date that's no later than midway through the session. I should have some confirmation about that new date this morning. If you have registered for Trauma Awareness Day, then you'll get info on the new date. If you have not registered and would be interested in attending, we'd love to have you. We will reopen the registration once I have the new details. That's it.
And will you just send out an email to the same group?
Yes.
Giving us the new date? Okay.
I sure will.
Well, I'm glad they let you know that, Cheryl, because that's a shame. That would have been a shame to have everybody there and then not be able to interact,
I know. And
Yeah.
they were the legislative aide in Senator Kirkpatrick's office was shocked. She said, we just found this out. So the hardest thing has been trying to find a room to have our breakfast and our meetings, because everything is already booked by this time. So I think we have been able to come up with something, and I should know something a little bit later today.
And the good news is there's no hard ask for anything this year. We're just basically
Right.
thanking them for their support because, we got the additional 4 million last year. And,
Mhm.
we've had some great wins this year with the system, with some expansion. So, it's great to go back and have something to thank them for.
Right. Yeah, and let me just mention this too, because this hasn't actually just been, widely announced. We are going to recognize 4 of the state lawmakers. We've got a couple of trauma heroes and then a couple of trauma champions. So as many of us as we can get to attend, just letting them know how much we appreciate their support for advancing trauma care in the state. If we can make a big showing, that is even better. When we're not asking for something, we're just saying thanks. That's it.
All right. And I see at the bottom, we've got access to specialty care, but that's deferred. So is there any other business or anything else that anyone wants to mention? We are 9 minutes from our stop time.
I have something.
Okay.
The GQuip winter meeting room block ends today. So if you have not booked your room, please do so. Thursday night's available through the link. But if you want to book Wednesday night, I know they were accepting some bookings if you call them. And for the GQuip winter meeting, the required attendees are the TPMs, TMDs, and the trauma administrators. So please make sure you book your room. Registration deadline's going to be February 7th. That's all I got.
I'm happy to hang on the line, Kelly, for folks after everybody leaves, if folks have any more questions about IRR or PTSF directly, since we have a few minutes. Okay.
Okay. All right. Well, thank you, everyone. If no one has anything else, make sure you either scan or click on the link to document your attendance.
Great job running the meeting, shotgun with 3 minutes notice. Good job, Kelly.
I'm just glad I'm at the office in scrubs and, looking normal today. All right. Is everybody getting off?
Thanks, ladies.
Yeah, thanks, guys.